Right, I think the doorbells stopped ringing with such a great frequency now, so I think we'll make a start because we've got a tight agenda in terms of time, because we appreciate everyone's busy at the moment, ahead of holiday season and covering for holiday, etc. So make a start. My name's Carl Walker, and I'm the NQICAN chair, and I'm going to be hosting the session today, and it's really great to be able to do this webinar in collaboration with HQIP and in particular Hannah Wright, who's going to be talking to us this morning, who's an actual doctor in training herself, and she's going to be sharing and reflecting upon her experience of having a year out as part of a fellowship working with HQIP and the National Audit agenda. So I'll introduce Hannah shortly. I've just got a few slides I want to cover in terms of context of the session. So I can see people still coming in. So if you're just coming in and just if you can fill in the attendance, sign in on the chat, please, and also fill in the poll. It looks like they've got majority of network members here, but we have got other colleagues here, which is great. So NQICAN, if you haven't heard of us before, I assume you have. So and I'm going to go through these slides quite quickly, but they will be shared afterwards, and also we are recording the session so that if you are a little bit unfamiliar with some of the information that I'm going to share, then you've got that as a reference point. But ultimately, NQICAN is a network of professionals where we all come together and work together to increase the quality of the projects that we provide and support, so that ultimately we are working together to improve patient care. And there's lots of different types of projects that we might be working on as part of our networks, but ultimately that's our new common purpose. And within that, we've got some core elements that we focus on, and one of those is linking in with the national programme, and that's why this session's going to be focusing on that. But it's also around ensuring that clinical audit is integrated into the wider quality improvement agenda, which sometimes it's not. We've got a forward plan. That's a very busy slide, and I don't expect you to read that, but all it is illustrating is that we've got lots going on across our networks, and what we're trying to do is work together. We've all got busy day jobs, but it's very important that we do networking and working together and sharing solutions, and we do that through our regional network meetings, and it's great to see a lot of the chairs signing in on the chat. And also, as I say, we've got things like the forum, we've got our website, we've got our national steering meeting that we have at once a quarter, and all of those informations and outputs are on our website and forum. So if you haven't aware of our work, then please have a look at those, and I'll put the links in the chat when I've finished speaking. So today's session's all around supporting doctors in training. Hannah tells me that junior doctors is sort of old speak now, so I'm going to try and use the word doctors in training throughout this morning's session. And it's important to remind ourselves, if you are working with doctors in training, that they have got requirements to do quality improvement as part of their foundation curriculum. And the lobby keeps covering up my slides as I'm talking, so that's it. Oops. Yeah, so as an FY, as F1,
I'm happy to take that on, admissions
okay.
in.
Elka, I can hear you. That's it, great. Another one I can hear the voice of one of our regional chairs. And yeah, and then yeah, so F1s just need to show evidence that they've been involved in a project, and F2s need to say that they've actively been involved in some aspects of the improvement cycle. And in my day job, I've been supporting trainees and doctors in training for many years. And one of the things that I've heard recently is that, I don't want to do a clinical audit, I want to do a quality improvement project. Well, hopefully most of us on the call today will know that clinical audit is a quality improvement process. And I've had a few battles over the years as being chair in terms of getting that message out to the powers above. And this document was a particular sort of root cause of that confusion, because in there it was almost saying that clinical audit is old hat and quality improvement is the new bright future sort of thing. But actually, I think what the document was referring to was audit for assurance and to the spot check, whereas trained professionals know that clinical audit is an improvement cycle. and is very much a quality improvement process. So we've written a blog around that in terms of the response to that, and we've been working very closely with the Academy for Medical Royal Colleges since then in terms of proactively taking forward work through the National Audit Programme and local programmes and providing training for trainees. From that document, I thought this was a very powerful slide in terms of Stephen Pauls, who's the new, well, not new, he's 2 years now, so medical director for the NHS. He was saying in this document that in order to practice medicine in the current day, a core understanding of quality improvement is as important as an understanding anatomy, physiology and biochemistry, which I think is a really powerful statement. And certainly when you're doing your doctors in training talks on induction or as part of their training, I think that's a powerful slide to put in, really, because it really does make you understand that a 21st century doctor does need to know about quality improvement. And back in my day job, we had our Doctors in Training Quality Improvement Awards last week, and it was great to see all of the work that they've been doing. And we had a showcase and some awards, and they're the winners of the competition. So again, just to reiterate, it's important that trainees meet their curriculum and update their e-portfolios, but it's much more rewarding if they do a project that makes a difference and something that they can use to celebrate and help their careers as they progress. And I know Hannah will be talking a lot more about that and how that we can make that more easier for doctors in training to do an effective project and link it in with the national project program. So I think that's yeah. So that's my last slide. So I'll just stop sharing. Okay. Okay, great. So we've so the poll is showing that we've got yeah, lots of people on the call, which is great. And the majority of the people on the call are colleagues from the networks that are supporting junior doctors and doctors in training to do QI projects. So that's great. So it's so I can see Hannah on the screen, which is great. So over to you now, Hannah, then to go through the main part of the session.
Thank you very much, Carl. Can you see my slides now?
Thank you. Yeah.
Thank you. So thanks so much, everybody, for joining. It's a pleasure to be here, and I know you've all given up your lunch break to be here. So today I'm just going to present to you a bit about the work I've been doing with HQIP this year as a clinical fellow, particularly looking at how doctors in training can better be engaged with the National Clinical Audit and Patient Outcomes Programme, and indeed quality improvement, as you've discussed, Carl. So just an overview about what I'm going to talk about. So I'll give a little bit of context about who I am and how I've ended up doing this project. I'm going to share my story as a trainee of my experience with engaging with the National Clinical Audits. I'm then going to share some of my survey and interview results that I've got from speaking to trainees this year. I'll then move on to cover a bit of the work that I've been doing with some colleagues at HQIP to help try and start to address this issue. I'll touch on what I think the benefits of involving trainees in this work is, and then share a couple of initiatives I've come across, some locally and some actually within the audits, to better involve trainees. And then I really want to just open up, as Carl said, to a discussion so that we can share what's going on in different sort of trusts and departments locally, and hopefully help think of next steps as to how to take this forward. So context. And a little bit about me. So I graduated in 2016 and have done 4 years of training postgraduately. So I did 2 years of foundation training at Guy's and St Thomas's in London, and then went on and did 2 more years of core medical training again in London, which finished last summer. And then after that year, I took I guess a formal year out of training, and I'm currently a fellow on the Faculty of Medical Leadership and Management's Leadership Fellowship Scheme, and was lucky enough to be placed at HQIP, where I've been remotely, of course, since September. And when I joined HQIP, I spent some time having a look through some of the audit publications, the outputs, and looking at a number of the audit provider websites as part of my sort of pre-reading. And my initial reflection was that I had a really quite poor understanding as a trainee of all of the audits and the outputs that were out there. and felt that this could have been really quite useful for me as a trainee in audit and quality improvement activity. And so when I joined HQIP, I had a discussion with my line managers about this, and this is really where this project came from. So just to touch on, I guess, my story. So in my core medical training year, so my 4th year after university, so, I was relatively senior SHO. I worked on a hyperacute stroke unit, so 6-month job on a stroke unit, which was really busy. But stroke, as lots of you will know, is one of the departments where the national audit is really part of the day-to-day work. So that's the Sentinel Stroke National Audit Programme. And as a trainee, I was aware that the SNAP audit was ongoing, but more by way of the fact that I needed to record certain bits of information in the notes and make sure I had certain times and parameters documented in my discharge letter. But as a trainee, I had no real understanding of why we were doing this, and actually didn't really have a clue about how I could have got more involved with the audit and how I could have actually, registered to access the data or use the outputs actually to support improvement activity on that job. And so what actually happened was I spent 4 months essentially just doing my day job without really thinking about audit or improvement. And then 2 months before the job finished, I remembered I needed to do some form of a project in order to pass the year. And so what actually happened was I did a very small sort of 1 cycle quality improvement project with one of my colleagues that was a bit more of a sort of tick box to help me pass the year, if I'm honest. And it didn't really provide rich learning for me, and I don't think it has led to sustainable change or improvement in the department I was in. And I'll circle back to this example at the end to think about how I could have potentially made more of that opportunity with the information I have now. So onto the project. So the first thing I did really was do some scoping and ask trainees, both survey and interview, and I spoke to a number of clinical audit professionals as well. So surveyed over 100 trainees, and the first question I asked was just simply, are you aware of the National Audit Programme? And as you can see here on this graph, around 50% of trainees said they'd never heard of the programme. 10% of trainees stated they'd actively been involved with the programme, and this was largely limited to data collection rather than any really improvement activity related to it. A similar proportion, so 11%, said they'd read the publications from the audits, and 30%, and this would be the category that I would have fitted into, said they were aware that it was going on, but not really sure of the relevance of it or hadn't actually engaged with it. And then I asked the same question for the clinical outcome review programme, and as you can see here on this graph, more trainees, so over 60% of trainees stated they'd never heard of this programme, and only 1% of trainees actually had been involved with it. And again, the same proportion, so 11% of trainees said they had actually read the publications. And I think, my reflection on joining HQIP was that I got a lot of really useful information from having looked at those websites and those publications. So I think this really showed us that there is a gap here. There is more that can be done to actually help trainees engage with this programme. Then I went on and asked this question, which I think is really interesting, which a colleague at HQIP asked me when I joined, which is, how do you know your department is doing a good job? And there's just a few quotes here from the trainees who answered this question. So you can see here in the green and the yellow, 10% of trainees stated they wouldn't know, and they wouldn't know how to find out. So, you've got no evidence and that they wouldn't actually know where to look. The most common answer was feedback. And this was quite vague. So trainees talked about feedback from patients, feedback from other members of staff, and general staff morale. The next most common was audit, so clinical audit, but trainees generally refer to the fact that the audits were ongoing in a department rather than actually how their department was performing compared to standards or benchmarking. 15% of trainees mentioned benchmarking, so either to local or national standards, but only 2% of trainees made any reference to national clinical audits at all. And what was quite clear from this question is that, you know, trainees generally didn't seem to have a very good sense of how good a job their department is doing. And I think there's a number of reasons for that, including the fact that people rotate through departments and through hospitals so frequently. But again, this looked like an area where actually the National Clinical Audit Patient Outcomes Programme could really help with this understanding. So then went to ask trainees, so why do you think engagement is so poor among trainees? And I'm just going to share a couple of quotes over the next few slides that I think sort of sum up quite nicely what trainees were telling me. So this quote in the blue here is from a senior anaesthetics registrar, so almost finished her training, almost a consultant. And she said it just seems to be something that the consultants take control of, and actually as juniors you're just told, you know, fill in this form, but don't necessarily really understand why or see the outputs from that. And in this quote, she speaks about how when she discovered the hip fracture database was amazed and about the fact that you could actually compare your performance to other hospitals, and suggesting that actually if you engage trainees with this, then they would feel the responsibility just as the consultants do. This quote here on the right in green is also from a registrar who said, you know, again, she'd collected data but didn't really have a sense of how their department was performing against others. So kind of, again, where this was leading into. And just a couple more. So again, this quote in the blue here, this was also an anaesthetics registrar, but it explains quite a similar experience to what I had, which is that the exposure for trainees isn't great, or it doesn't feel like it is, and that whilst you know that they are ongoing, it's more because you haven't filled in certain bits in a form rather than actually seeing where this information goes and really understanding why you're doing this. And the quote here on the left is for an obs and gynae registrar. And again, obstetrics is one of the areas where the Embrace clinical outcome review programme is quite integral to the work. But again, she's saying as a junior trainee was aware of it, but didn't really understand what it meant. So I then went on to ask trainees actually more generally about barriers that they experience to quality improvement. And I think just worth me touching on why I actually asked about quality improvement and not clinical audit. So it aligns with lots of the stuff Carl said at the beginning. But I think, as we all know, there's a drive now for not just doing clinical audit for a quality assurance purposes, but actually clinical audit to support improvement. And there is obviously this drive for trainees in actually being part of the whole improvement cycle. So the audit as well as the improvement activity and the kind of so what question from there. And this was really interesting. And this word cloud just shows the key themes that really came from the surveys and the interviews. So the most common thing trainees said was a lack of support. So feeling like they didn't have support from their clinical supervisors. So perhaps they came across a barrier or didn't know who they should engage, but actually didn't really know necessarily who to go to for help. And this encompassed the fact that perhaps their senior clinicians also didn't have particularly good understanding about quality improvement or methodology. And also that actually their sort of formal educational and clinical supervisors, whilst they help with their portfolio, weren't necessarily actually engaged with the kind of QI activity they wanted to get into. And also in this theme, it was juniors sometimes expressed that they found it difficult to know who to contact in their trust. So be that in the clinical audit department or quality improvement or effectiveness department, that sometimes because you're moving departments, you're moving hospitals, it can be difficult to know that the team are there and actually how they can support you. The second most common was a lack of time. So I'm sure you've heard this time and time again from doctors moaning about time, but time in the day alongside busy jobs to actually fit this in. Generally, juniors are doing this after work, coming in on their days off to do this work. And also the fact that actually you're rotating so often that really getting stuck into a project when you're moving every 3 to 4 months was really challenging. Other things that came up again that you've probably heard quite commonly, but is the fact that trainees had poor understanding of QI methodology and actually how to undergo a project. When I was at medical school, I didn't have any teaching on quality improvement at all. I think maybe an F1 told me about it in my, very final bit of my final year, but lots of trainee doctors haven't had undergraduate training on this, so kind of learning this on the job in many cases. Difficulty accessing data, both in terms of knowing how to do that and actually the time taken to get their hands on the data. And then again, another common thing was this resistance to change. So feeling like you're being told, no, this is how we've always done it, or, oh, we can't make that change, and organizations not really being receptive to kind of innovating. And I think there are a few areas among these barriers where actually engaging with the national programs can really help to break down some of these barriers for trainees. So, difficulty accessing data. Well, actually, if we can get our trainees registered onto the national clinical audit portals to be able to access the data, then that is a potential way we could help break down that barrier, at least for some of the data. This concept of lack of time, I think engaging with the national programs can really help sort of prioritize topics that show that your department needs improvement, which can help cut down that time that I've described where you're sort of thinking about an improvement project but not sure what to do. And equally, if you're accessing data that's already been collected, that can also help save time. And then this sort of resistance to change. So feeling like the organisation aren't interested in the project that you're doing, which is something that lots of trainees described. Actually, if trainees can be working on projects that, the department or trust want to improve because the national audit has shown needs improvement, then again, that can help really break down that barrier. So I then went on to just ask the trainees, what do you want to know? So how can we work to address this? And the key things that trainees said they wanted to know, well, is, what is the National Clinical Audit and Patient Outcomes Programme? And to get a sense of which conditions it covers, the fact that it's a really broad range of audits. They wanted to understand a bit more about the impact to help with that, to help understand why they're doing this, why you're collecting the data, why you're maybe staying after work to do this. And then the rest of the points really focus on how actually trainees can get involved. So be that the data collection, be that using the outputs for improvement, or actually accessing the reports and data. And another thing that I haven't put on here because it's more focused on the national programs, but trainees also expressed, lots of them wanted actual training in quality improvement methodology to help support the improvement projects with this information. So just to touch a bit on what we've done or in the process of doing at HQIP. So one of the things that a number of trainees suggested would be helpful, and Carl and others also suggested, was some e-learning, not just focused on one audit, but broadly about sort of the programme and how trainees can engage. So through speaking to a number of trainees, linked up with Health Education in East of England, which has around 4,000 or 5,000 trainees training there. And we've worked to create this e-learning with the Health Education East of England, which will be launched in the East of England in a couple of months, just focusing on what the NCAPOP programme is and how trainees can engage with this to support quality improvement. So this is video-based, video and text-based e-learning, and it's required me to obviously get quite au fait with, Doodly and other video software. So I've been practicing my skills at that this year. And this e-learning will also be launched on the HQIP website in due course. And obviously, once that is launched, we will let your networks know. But this hopefully will be able to give trainees a bit of an introduction about actually how they can engage with this programme and get the best from it. And then a couple of other new resources which are hopefully launching again in the next couple of months. So I think, Carl, it was you who suggested this top tips idea, but we've created just a top tips one-page infographic for trainee doctors to suggest the ways that they can get involved with the national clinical audit programs. So hopefully that's something that can, be sent around on emails or is stuck on walls if we're still printing things off, just to really highlight high-level ways that trainees can engage. And then on the right here, created this resource again, which hopefully will go live in the next month or so. But this is just a list of all of the open access resources to support quality improvement that are produced by the audit providers. Because again, I found that I was finding loads of really useful information that I don't think I'd have just stumbled across as a trainee. So it's just having everything in one place to, again, hopefully make this easier for trainees. So why do I think this is important? Well, so as you know, every trainee has to undertake at least an audit or a quality improvement project every year for their curriculum, which means actually in every hospital and trust, there's hundreds and thousands probably of these projects ongoing. Often these do end up being sort of small scale, potentially single person, potentially tick box projects, because trainees have to do this to pass the year. But I think it's important to note that, you know, generally speaking, trainees do really want to make a difference. As Carl's mentioned with the, you know, seeing trainees engaging with the QI in your trust, people want to do more than just their day-to-day job and actually want to feel like they are making more of an impact than just what they do on a day-to-day. And I think in my experience, some of the most rewarding things I've done have been really proper improvement initiatives and projects. And I think that actually if you can sort of align the two and effectively engage trainees with the National Clinical Audit and Patient Outcomes Programme, alongside the sort of improvement side of that, has massive potential benefits. So not just for trainees in their learning and actually, you know, the portfolio side of it, but actually for improving patient care and sort of aligning those improvement projects with the needs of your organisation. So just going to really briefly share a couple of initiatives that I've come across to involve trainees, and these are just things that I've come across through speaking to people, and I'm really keen to hear, you know, what's going on in your networks, especially. So this is an example from Kingston Hospital. So this was a couple of their F2s wrote this up as a bit of a case study. And actually at Kingston Hospital, what they do with foundation trainees is get trainees to rank the audits in their areas of interest, and then they actually allocate audits to trainees. So these are a combination of high priority audits locally for the trust, but also national clinical audits. And in this process, they give each trainee a supervisor and outline what the needs for the trainee are and what the supervisor needs to support with. And I think these quotes show sort of potentially the benefits of this for trainees. So this one on the right, which again was from an F2, saying that it made them feel like they were part of something impactful rather than just something they'd done to tick a box on the portfolio. So again, I think this is quite an interesting way of engaging your most junior trainees in this work. And then just to think about what a couple of the audits do that may be relevant to signpost for trainees in your organisations, but the National Emergency Laparotomy Audit actually sponsor prizes for trainees at their national conferences. So these prizes are for the best posters that demonstrate the use of their data for improvement. And I think the prize is a small cash prize, but actually it's a big incentive for trainees actually to get a poster at a national conference, and, you know, winning a national prize is obviously, you know, excellent for trainees. So I thought that was a really interesting idea. And then just highlighting a few other bits that are going on within some of the other audits. So the National Asthma and COPD audit, as part of their QI work stream, are actually training up quality improvement coaches across the country to be able to deliver local training, so sort of peer-to-peer training on QI and actually using the audit for quality improvement. This is open to trainees and all healthcare professionals, which I think is a really interesting idea and great way of sort of spreading this message. The RCPCH actively encourage trainees to be involved in the quality improvement collaboratives that happen with teams in trusts. And this quote on the bottom left is just a tweet from somebody who was at, obviously pre-COVID, one of the quality improvement collaboratives. So again, actively involving trainees in the kind of MDT quality improvement approach and using the audits for that. And then the Falls, Fragility and Fracture Audit Programme and actually the National Early Inflammatory Arthritis Audit have clinical fellows and junior doctors actually sitting on their project working groups and steering groups to really try and get the junior doctor voice, you know, at the table to help shape their outputs. So just to finish, I'm just going to circle back to that example I gave from when I was on the stroke job at the beginning, just to touch on, if I knew then what I now know, what would I have done differently? So, you know, if I had come into that job with this information, or even if when I'd rotated onto that job, our clinical lead had given us a really short induction about SNAP, explaining, you know, what it is, how to access it, how we could have used it, and a bit of context about how our department was performing. I really easily could have gone onto the SNAP website, had a look at the annual report, and from that report, even from the executive summary, it would have been really quite clear about what the key domains and indicators that were measured for SNAP were. And I think this would have helped me contextualize why I was recording certain information in the notes, but also had in the back of my mind where potential areas for improvement or projects could have come from. I then could have registered to actually access the data on the SNAP web tool, and I know that in my department that was entered in near real time. So actually then been able to compare how my department was performing against others in the country, and again, highlight potential areas for improvement. And I think with this information, I'd have felt much more empowered to go to a clinical lead or the MDT and actually suggest areas for improvement or potential projects, or ask more actively about where I could have got involved. And I think this would have sort of led to me being part of a much bigger and better project that was ultimately better for the patients, the organisation, and my own learning, really. So that's plenty of me talking. I will stop sharing so that, Carl, you can hand back to you and you can chair the discussion now.
Okay, thank you, Anna. Let's take a clap. Yeah, that was a lot of work there that's surmised into a nice few set of slides there that I can see people are asking, are they going to be available? So just to confirm, they will be, and the video will be available afterwards as well. So so that's great. So yeah, so again, now I can see one or two people. If you're not shy, put your cameras back on. If you're shy, keep them off, that's fine. If you haven't got a camera, I know that some people haven't, but if you want to go to the floor with your hand up in age-old tradition, or put a comment in the post if you've got any questions to Hannah, please. I can see quite a few. Nice to have Sarah Chisel with us now, the General Secretary of NQICAN, on the call as well as Becca, our comms lead, as well as quite a few of the regional chairs, which is great. So I can't see any hands, although there's a lot of people on the call. So there we go. I've got a hand here from Samantha Eaton. Is that right?
Yes, it's right. Hi, Carl. Hi. Hannah. That was very interesting. I'm actually from Kingston Hospital, and I was going to say too, we actually do a presentation at the FY and F2's inductions. Sorry, one hold up. My husband's on a meeting too. James. And the
You've muted yourself, Samantha.
Sorry, I had to.
Oh, that's all right.
I was just telling him it was being recorded. And we actually have them on the committees as well, so they volunteer at the induction if they would like to sit on our clinical audit group, and also our clinical effectiveness committee, and they also have junior doctor membership on the end of life steering group. So we're trying to involve them at a strategic level too, so they've got a direct line. So we have maybe 6 representatives this year. One of them, Lucy, is very active actually, and in fact she's staying on for CT post, and she's going to support junior doctors doing a follow-up project and induct them with that project that they've been allocated this year. So we've actually already allocated next year's projects now going forward, so they know exactly what they've got when they come in. And we found that's really, really effective in terms of engagement, and they're very happy because they know what they're doing and where they are.
Excellent work, thank you, Samantha. That's a good. We always like to have case studies where people have got successes and they can share. So that's what networking's all about. So that's brilliant. So I know Kingston have done quite a lot of work with National Data Opt-out as well. So we're very grateful of your help that you've done for that. Thank you. Okay, so Lynn K. Han, we've got a question, please.
Sorry, my question is actually to Samantha, just on the back of what she's just said. I didn't quite. I know you said you worked at Kingston Trust or hospital, but I didn't get what your job role was. So I was interested. Oh, sorry.
Sorry, I'm one of the clinical audit improvement facilitators.
Oh, okay. So it just interested me that you said that you allocate the junior doctors a project. So when you say a project, you allocate the national audits from the clinical audit team to the juniors. It doesn't come from the clinical staff. That was my question.
Yeah, we have all of the national audits listed, and also board requested projects, or if there's something where we consider there's a high risk, or if there's been some action that we need to do follow up from a national audit. So we have a whole selection of projects that are trust priorities.
Yeah.
And the F1s and F2s all get allocated one of those projects.
Okay.
So we particularly wanted to focus on HQIP around end of life care, which involves some auditing. So we allocated 4 of the junior doctors to that project, and they will be involved in the action planning, and they will come and present to the end of life group the results as well. And so they're sort of involved in the presentation, but some of the F1s may be just at the data collections phase, and the F2s will be much more HQIP that's got an audit component to it. And in case of Lucy, she'd done the end of life prescribing, and she and another colleague actually did the project and then came back and presented the results, and that she did the follow-up audit. And we've had a few doctors, if they've stayed on to the F2 year, they will carry on with the project they started in the F1. If they come into A&E, if they're in their first rotation, they get an RChem project to do when the RChem projects come out. So they know exactly, and same with sexual health, they'll do specific sexual health projects if they're doing a rotation through there at a specific time. So they all get it when they come in the August, basically. So we know exactly what they've got in that August time.
Great, thank you for answering that.
Okay, very good, thank you. And that's the beauty of having these open forums. It's you can add context to the discussion. Brilliant. So thanks for that again. So Raoul Techie here, I can see Raoul on the screen. Hi, Raoul.
Hi, I'm Dr. Tekira from Luton, one of the consultants. Thank you very much, Hannah. That's nice involvement and encouraging people to join. My question is, allocation is, it's very good idea that we at the beginning do give some projects to the juniors. But the problem is completion of them, because one of the factors you mentioned is the transience of the people spending in the department. Usually for FY1, FY2, I don't know about other hospitals, here it is 4 months, such a short period. Obviously, if the trainee is extremely motivated, yes, definitely they'll do that. If they're not, how are you ensuring that completion of the projects are done, and then you're just making sure that they have just completed at least the job given?
Yeah, really good question. Thank you. I think your point that one of the points is that this isn't going to be every trainee's passion, quality improvement. You are going to have some people who are particularly keen, audit and quality improvement, who are particularly keen and really want to get involved, and that makes it easier. I think for the others who are in some sense doing it because they have to, at least at the beginning, there's things that we can try and do, like to try and break down these barriers that can at least help them engage more in the process and actually feel like they understand really why they're doing it, beyond it being, I need to pass the year, because that is ultimately not particularly motivating, really. But actually make them feel part of a team, understand what the benefits are. And actually, if they're coming in and they only want to be there for 4 months and to do that in your department, perhaps because it's not their area of interest, then I think trying to make that okay, in that there's a way that they could hand that over to somebody incoming, so that they're a part of the process rather than trying to do everything in that time, if that makes sense. Yeah,
I think it's, Anna.
Yeah, it's explain a bit of kind of explaining of the reasoning as to why you do it and the impact that can have. And I think what Samantha shared about getting trainees involved and having a bit of a path of escalation up, so that actually you do feel like something really sort of understood more about why I was doing this, what the impact was, and I think that really hooked me in. But again, I think the caveat is that there will be some people who aren't that engaged in this, and they're more interested in research or other bits, and I think that is also okay. But just to really do our best to engage those people who are potentially sort of, you know, could be interested if they're hooked in, if that makes sense.
Thank you. Thank you.
Thanks for that question. And again, from my experience, definitely, if you've got a good audit lead or a supervisor that actually does things in batons, and the batons handed on to the next rotation in terms of where they've got with the project, and it might be that we've implemented this, but we've not measured it to see if it's been impactful. So again, that's where the constant in terms of the supervisor or the audit lead and ourselves help with that in terms of doing that, but also getting the contact details of that trainee from the first cycle and keeping them in touch with what's happened with the project so that they can see the end and the output. And we're certainly sending e-certificates for the portfolios for anybody who's involved in any part of the cycle as per the curriculum that I shared at the start. So, and interestingly, when we put on the poll for the barriers, short time on rotation was the highest response from people on the call today. 40% were saying that's the main barrier behind doing successful projects. So if we can try and do a model of doing something that's achievable and also realistic, smart model, really, isn't it? So, okay, great. So we've got another hand up. So Sarah Chisel. So, hi, Sarah.
Hi, thank you. And thank you both to you, Carl, and to Hannah. A really, really interesting piece of work, and looking forward to discussing more. Just a couple of points from my perspective. I think one of the things we need to think about is how we are nationally and within organisations defining QI. What does it mean to people? And actually encouraging folk to think about it's about quality rather than trying to put in silos. It's an audit. It's about quality. And actually that at the heart of what we're doing, everything we're doing, is the quality of care for our patients. And, you know, it's about the profession that we're in and what we are trying to do, and we are all involved in that. So that then builds on to my second point, which is actually, I think both at national levels, regional levels, organisational levels, we need to look at culture. And looking at the culture is, how do we ensure that culture is about a learning environment constantly, and recognising the different space that individuals are at different times in their career and in their different roles, and trying to build transferable skills so that actually, and at University Hospitals Dorset, we use the baton approach, and we recognise, and it might be that we write a letter for the individual to say they were involved in data collection or they've done some analysis, but we try and also build in that they're doing what's important within their department, so key priorities on the clinical audit plan, and it's supported. But each time, if we take that back to culture and we look at that, we are reliant on the individuals, supervisors, their clinicians in supporting and enabling those folk so they can take the project forward. If you're in a rammed ED department, you're on a short rotation, you may have very, very little time to be able to actually undertake a quality project, be it audit, be it etc. But actually we can make a difference by actually enabling folk to understand what quality is and why it's important to look at it, and how every single thing we do makes a difference. So it's just a plea to everyone to think about that from a national level as well.
And
Thanks, Sarah. Very good points there. Let's say one of the things with our new common purpose is that if we put the heart at what we're doing, everything we're doing is linked to patient care, then and ultimately you can find a way, and everybody's got a common purpose there, because it's actually, there's a lot of semantics with the phraseologies we use within the NHS, but actually ultimately it's all about, you know, providing good quality care for patients. So great. So great, Kim Brazell from HQIP. Great to have Kim with us, Kim. Thank you.
Hi, thanks, Carl. I just wanted to add a comment actually from the previous question about doctors being transient, and I think it's just worth mentioning having some patient and public involvement in some of these QI programs, because there's a real opportunity here where you can work with your PPI teams within your trusts and get patients involved, and they can continue on those projects even after doctors have moved on. And in fact, some of the examples Hannah mentioned with NAILA and FAP, some of those success stories are in part due to the patient groups that have been involved, that continue those programs and projects. And it's really just good to have them on board. And I think that can really influence people up top and your communities as well.
Great point, Kim. Thank you. Diane, our West Midlands Chair, welcome.
Hiya. Yeah, Hannah, that was a great presentation, really interesting. I think my comment is around it's not so much that we can't engage the junior doctors. I think it's a lot to do with some of the supervising consultants as well. So some of the senior clinicians, where they're kind of dumbing down audits, saying it's not important as much as seeing the patients. And I think that's where we struggle, and that's why in the poll I put that it's to do with the protected time as well. So if the juniors manage to get protected time to do the audits, then we will get some better outcomes, because at the minute it's right, they see it as a tick box exercise that they have to quickly rush through because their clinicians want them on the shop floor managing all the patients and that. So I don't think they're given the time to do the actual quality improvement.
Is there any protected time in the job plan now, Hannah, for FYs and 1s and 2s?
It's really variable. So it generally, once you get to registrar level, you do tend to have protected time, and lots of the trainees I spoke to said they never really engaged properly until they did have, days out to do it, or at least to be able to do a project properly when you've got the headspace and time. I think in some places, foundation year doctors get a tiny bit, but in my experience, I didn't get any protected time, even through my core medical training. It may have been rotated, but it ends up not happening because you're short or something. So I think there's still a big gap there, and I completely agree that this is quite new stuff for lots of consultants who, especially older ones, didn't learn about any of this stuff at all. I didn't learn about it in med school, so actually it's newer, and I think it's winning those people over as well. And I think it's about realizing that it's not using trainees to do this, but actually they just have to be facilitators to let the trainees do this work in some way. It doesn't have to be, do you know what I mean? That they just have to show the trainees where they can find information or who they can speak to, or refer them to the quality improvement team as well.
We're just putting a programme together now. We're going back down to the medical students because they're the future doctors. So we're kind of getting those guys on board, starting with the audit and quality improvement training. So it's our first time in September. So we're going to see how that pans out and see whether it does make a difference.
Yeah, that sounds like a really good idea.
Yeah, and in terms of our local trust, what we've tried to do recently is have all of the national standards and find out where we are in the benchmarking, and then where we're an outlier negatively, we've then got what we're doing in terms of improvement work for this, and have we got a grip in terms of taking this forward, and then that's going to feed into suggested projects for the juniors going forward, on each rotation at the start of it. They'll have a list of trust-wide audits that we need help with, and then also national audits that we need help with, because both of those, some of the data is already collected, so we're not asking them to be data removals anymore. That they can actually do the focus on the improvement bit and the human factor side of it, really, in terms of finding out why we aren't doing what we should be doing, etc. Okay, so we've got Vicky Patel. Hi, Vicky, our Yorkshire Chair.
Hi, thanks, Carl. I've just got another question for Hannah about, is there a difference, or have you looked at certain areas where there's high numbers of junior doctors, like anaesthetics, say, and how they manage their QI projects, and also in terms of the junior doctors' experience, because you've got more juniors looking for projects as well?
Yeah, thank you. Really good question. So I haven't looked at the data separated by specialty. I probably could, because I have all that information. I guess anecdotally, what I found from speaking to people was that I think trainees, once they're actually within a specialty, so like after your foundation and core training, and perhaps you've got a Royal College or you've got quite close contact with consultants, it can actually be much easier then. I think there's a number of reasons. You're more senior, you've probably got protected time, and you're sort of within an area. but I think for those that are still rotating, don't have a specialty, perhaps don't have consistency with consultant contact as well, it can be more difficult. And the other thing, again, anecdotally from speaking to people, I think anaesthetics and surgery, where you actually do have a bit of that downtime, perhaps where you're speaking to members of the team and thinking about things between cases or whatever, that can also be quite helpful. Whereas, you know, some of the medics I've spoken to say, we spend most of our time on the wards. You don't necessarily have that downtime. You know, it's not downtime necessarily between cases, but you know what I mean, that time to really think about things and spark a conversation. And I think especially for your juniors, when you're often rotating with that as well, it does just make it very difficult. I think the other thing to add, which is sort of linked to Sarah's point, is that I think the concept of it being a quality improvement project is also a bit of a problem, because people see it as this discrete thing that, you know, you do and then you tick it off and then you've done that and then you leave it. But actually just embedding this somehow in this culture is that this is a constant process. It's an improvement process. You're a little cog in the machine, rather than saying, I'm going to come in and do a project and then leave, which again I think is easier when you're a bit more senior and you have that length of time in the same place or with the same people.
Okay, thank you, Hannah. When we have these chats, it always reminds me of that Hugh Grant does an audit parody that's a junior doctor put on there on Twitter recently. I'll put a link to it in a moment, but it was actually talking about all of the different scenarios that junior doctors find themselves in, and sometimes find it very hard to say no. So they end up, agreeing to do things that they haven't got time to do, and they do it in their own time. And say that in itself gives a negative, feedback and experience for the trainee. Just got interesting news come up on some popped up, so that's better. It's gone. Yeah. Okay. So I can't see any more hands up at all at the moment. So. Okay, and we are almost towards the end of the session. So any final questions that anyone's got? Okay, as I say, so thanks for everybody attending. It's great to see so many people on the call. I think we got almost near to 100 at one point, which was great, and most people have stayed online, which is excellent. So we have been recording that, so we will share it on the forum and via the usual channels, via your regional chair, etc., and the slides as well. So part of us, as we know with our forward plan, this is just to start the conversation. So we will try and pull together some outputs, but also continue to share best practice models like Kingston have been sharing today, and other people that have posted in the chat. So I'd just like to thank Hannah and HQIP and everybody from the NQICAN network to working together on this important topic. And there's lots of room for improvement here, and I think there's been lots of suggestions how we can take this forward this morning, or this afternoon. So thank you very much. So keep in touch, keep involved in your networks, and let's work together to improve patient care in our profession. So thank you, everyone.